Thank you very much. Good afternoon, everybody, and welcome to West Berkshire Health Scrutiny Committee. I'm Councillor Martha Vickers, Chairman of the committee, and the members of the committee present this afternoon are Councillors Alan McCrow, Paul Kander and Stephanie Stevenson. Councillor Jeffrey is attending on Zoom, and Councillor Alan McCrow is substituting for Councillor Nick Carter, who can't be with us today. Council officers and external partners joining us to advise and support the meeting are Paul Coe, Executive Director, Adult Social Care and Public Health, Anne-Marie Dodds, Executive Director, Children's Services, Councillor Heather Codling, Portfolio Member for Children's Services, Stephen Bow, Consultant in Public Health. Have we got Matt Pearce? Is he? No, we haven't got Matt Pearce. And we will later on have Fiona Warby, Lead Officer from Health Watch West Berkshire. So from Eastfield House, hopefully we'll have Dr. Emma Featherstone, Dr. Anne Maloney and Liz Pope, who is the practice manager from Buckinghamshire, Oxfordshire and Berkshire West Integrated Care Board. We will have Helen Clark, Deputy Place Director for Berkshire West, Sanjay Desai, Associate Director of Primary Care Operations, and Daphne Barnett, Interim Associate Director, Complex and All Age Continuing Healthcare. Vicky Phoenix is the clerk for the meeting, and the meeting is also being live streamed via YouTube, and Thomas Radbourne is our host today. Before we start the proceedings, I'd like to explain for the benefit of members of the public who may be watching that this afternoon's meeting is being held both over Zoom and with councillors present in the council chamber. The meeting is being live streamed on YouTube, so members of the public are able to follow proceedings. And please can I ask everybody participating in the meeting to make sure they switch on their microphones and invited to speak directly into them and to switch them off when finished speaking. If we hear a fire alarm this afternoon, we must leave the building immediately via the emergency exit. The assembly point is the Dolphin Car Park, and if the lockdown alarm sounds, we will remain seated and await instructions from officers. We'll adjourn the meeting until such a time as it is safe to proceed. Do members have any questions about the way in which the meeting will be conducted before we carry on? Nope. Okay. So, Vicky, do we have any apologies?
Yes, Chairman, we've received apologies from Councillor Nick Carter and Councillor Jane Langford, with Councillor Alan McCrow and Councillor Kander here substituting. Thank
you very much. So we'd like to confirm the minutes of the meeting held on the 23rd of September 2024. Has everybody had a look at the minutes? Can I have a sort of proposition to accept them? Yes, question?
Yeah, ask a question of Stephen. You were going to explore the data relating to self-harm rates of young people in West Berkshire. Were you able to share that information? Have I missed that, Stephen?
We did have a look at that, and I do believe that was circulated. So it might be in an inbox somewhere, but happy to circulate that again.
And would it have come via Vicky?
Yes, it would.
Thank you very much.
I think we did have some follow-up on that, possibly. That was in the suicide item, wasn't it? Yeah. Thank you. Thank you. Thank you very much for raising that, Stephanie, and we can all make sure we've received it. Thank you very much. Any other issues to do with the minutes? Okay, can I have a proposal to accept them? That would be you, Stephanie. And then I'll second, because nobody else was at the meeting, I don't think. Okay. So thank you very much for that. And I'll sign them. Very much. Okay. Everybody, all those in favour. Actually, it's only just me and Stephanie, isn't it? Because we were the only ones there. Stephanie, going to vote in favour. Thank you very much. Right. Anybody got any declarations of interest relating to items on the agenda? No. Okay. Vicky, have we received any petitions?
No petitions have been received.
No petitions. Okay. So short update from me. On Friday, the 22nd of November, Councillor Stevenson and I attended the BOB Joint Health Overview and Scrutiny Committee. And this is a joint health scrutiny committee which brings together the local authorities from across Buckinghamshire, Oxfordshire and Berkshire West. And on the agenda was an integrated care board overview from BOB ICB an update on the primary care strategy, and feedback from a working group on the Bob Integrated Care Strategy, Digital and Data Strategy. And this was an opportunity for members on the Scrutiny Committee to ask questions and clarifications. Councillor Stevens and I, we raised a few issues related to our area. One interesting thing we learned about was that in some areas, dental services are being commissioned in a flexible way to provide, particularly to provide appointments for areas of deprivation. So I think there's 20 areas where this is happening. So I've asked if we can be considered, because we do have pockets of deprivation in West Berkshire, whether we could consider for a similar project. So obviously we'll let you know if we heard back from that. We also heard that there's assistance for GPs who are struggling with providing digital services. So we know at least one practice, and I think it's in Nick Carter's area, that has a problem with digital services. So we've asked whether we can hear more about that, so that practice can be assisted. And we also asked about the adequacy of services for children with learning disabilities, because that's a particular area that Councillor Stevenson is concerned about. In addition to that activity, members of the whole Scrutiny Committee also visited Eastfield House Surgery in October to meet with GPs and the practice manager in order to understand the challenges faced by the surgery at their current location. Okay, thank you. Right, so we now move on to our first item on the agenda, which is about the proposed relocation of Eastfield House Surgery. And I think we've got on screen, have we got Dr. Emma Featherstone? Yes, I think I can see her.
Hello.
No, we haven't. No, Emma Featherstone. Dr. Anne Maloney? Yes. That was Dr. Featherstone saying yes, was it?
Yes, you got me. I'm Featherstone. We have, in fact, Dr. Mark Gallagher, who's instead of Anne Maloney today, who couldn't make it, sadly.
Okay, the sound is a little bit, sound isn't so good. So I don't know whether that's, maybe you need to sit closer, but it's a little bit sort of iffy, I think, what we've heard so far. So we haven't got, have we, the practice manager?
Yes, Liz Pope is also here, I think, on the...
So we've got you all there. We've got Dr. Emma Featherstone, Dr. Anne Maloney, Dr. Mark Gallagher, and Liz Pope, the practice manager. So one of you, I don't know whether Dr. Maloney is going to give us a short overview of the report that you provided for us about your proposal to move to a site south of Newbury College. Okay, and then members will have questions for clarification and maybe other questions as well. Thank you very much. I'll hand over to you. Thank you.
Thank you very much for that. Anne Maloney sadly can't be here today, so we have Mark Gallagher, who is also a partner at Eastfield House Surgery, representing us. Thank you very much for having us and for allowing us to speak today. My name's Emma Featherstone. I'm a GP partner at Eastfield House Surgery, and I've worked here for about 19 years. I'd like just to summarise briefly for you the events leading to our current proposal, just for a bit of background. So our current building was purpose-built 33 years ago for 4 GPs and for a list size of 8,000 patients. It was extended with the addition of 2 new consulting rooms in 2012, and this was part funded by the partners themselves at the time. Over the years, our list has steadily grown, and our current list size is now in excess of 15,500 patients. And we are informed that this is forecasted to continue to increase to in excess of 26,000 patients over the next 10 years due to the new development in housing in Newbury. In 2017, we raised our concerns regarding our premises size, and we began regularly meeting with the CCG, who have helped guide us through the process of looking for new premises. Our building size was formally assessed as being 68% undersized for our current list size, and we were therefore considered a priority with new premises. In addition, we were informed that the practice no longer meets with the NHS statutory guidance for both clinical, administrative and communal space. So for the past 7 years, we've looked at approximately 17 different sites in Newbury, And all these sites have either been too small or too expensive or not within our practice boundary. We've been outbid on land by property developers on several occasions. We've seriously considered operating on dual sites, but there are so many reasons, both financially and logistically, why this just doesn't work for us as a practice. In 2022, we were granted temporary planning permission for 2 cabins to be located within the car park. This reduced our already inadequate parking by 6 valuable spaces, but it did provide us with 2 extra consulting rooms and some more administrative space. But this is also now fully utilised and in continuous use. So we've used every inch of space in the surgery. We've converted corridors into consulting rooms, meeting rooms into group admin spaces. All our admin offices are shared. Staff frequently have to hot desk or just simply can't come to work on their chosen days due to lack of space. Some of our rooms have no natural light or ventilation and low ceiling heights, as they were converted into working spaces from cupboards. We've in excess of 50 staff working in the building, and there's only 1 single staff toilet. There's no shower, changing room facilities, and only a very small kitchenette in the form of a galley kitchen with really limited facilities. And our staff usually have to eat their lunch sat at their desk because there's no meeting or room or staff room. So as a consequence of our current working conditions, you can imagine it's difficult to recruit and retain staff. We desperately require more clinicians because us GPs, we've got very large patient list sizes, but due to the lack of space, we simply can't take on more clinical staff. We're really lucky, we've got a fantastic supportive team, but trying to sell ourselves to new prospective members of staff is difficult when there are other places to work with considerably better working environments and hours. It's also really difficult for our patients for many reasons, such as lack of appointment availability, lack of parking on site. Currently, we only have 1 disabled parking space in current use, and we often have to double and triple park in the car park, so that makes it very difficult sometimes to even access that space. Patients often have to stand in reception during busy surgeries because there's not enough room to provide enough chairs for them. And not all our clinical rooms are accessible to wheelchairs and scooters, which poses more difficulties for our disabled patients. So several years ago, we were lucky enough to be presented with the opportunity to work with Greenham Trust in Newbury College for a new purpose-built surgery to be developed on college land. It's incredibly exciting because not only will it provide new premises that is so clearly needed, but it will also safety-proof us for years to come for future growth in this size as Newbury expands. It's the best opportunity available also to NHS England, because Greenham Trust are a non-profit making organisation, meaning the rental return for the NHS will be cheaper and more affordable than with any other developer. Currently, we're waiting for a decision from West Berkshire Planning, and we're hopeful this will be in our favour, because currently there are no other alternatives available to us. Thank you very much for listening, and we look forward to hearing your views and any questions.
Thank you very much. Thanks very much for that, Dr. Featherstone. Right, members, I'm looking to see whether there's any hands up. I mean, we do appreciate as a committee the problems that you're in. I don't think anybody's disputing that you need to move. Councillor, I think it was just Councillor Jeffrey and myself that were able to attend the visit to your surgery. And really, I mean, it's amazing what you've done to make the most of your very limited space. But obviously it's a very stressful situation for you. So I don't think we're disputing that you have to move. Now, Councillor Jeffrey, you have a question.
Does that mean I can be heard?
We can hear you now. Yes.
Thank you. Well, I think that what Councillor Vickers has just said, I would echo word for word to say that we were impressed with what you managed to do with your little rabbit warren, and to actually still provide proper medical services out of it. I think we probably take our hats off to you. And the notion that you don't have to sell the notion that there needs to be a move to somewhere which is proper. The one problem that I foresee is the whole question of how do people, particularly if they're not especially mobile, how do they get up the hill to get to the college site. What are we expecting the public transport offering to be, and particularly and specifically during surgery hours? Have you got any kind of picture of how the ordinary person that isn't particularly mobile, isn't driving a car, and isn't really up to walking up the hill, is going to get up to the college site and to be close enough to walk into the surgery?
Thank you, Councillor Jeffrey. Thank you. I'll leave that up to someone to respond to. Thank you.
I think we would are hopeful that with the extra development going on the college site, not just with the proposed surgery, but with the other development, that better links, transport links will be made with the town centre. I guess the other thing to mention is that as much as there are people that walk to our surgery, the majority of our patients actually do drive, and we have a lot of comments, negative comments about the fact that people can't park very near the surgery, which creates difficulties, can't get into the car park in our current surgery, even though sometimes their mobility is quite poor. So I think actually the benefit of having the site at the college where there'll be ample parking, I think will benefit the majority of our patients. And I hope the transport links will be improved as a result of the increased development up in that side of town.
Thank you, Dr. Featherstone. Councillor Codling, is your comment on the transport, or is it something else?
Something else.
Can I just quickly add a comment on the transport? Yeah, I mean, you said the majority of your patients drive, Dr. Featherstone, but the survey you provided, I mean, it wasn't very extensive, and I think that might be another comment we might make. I mean, you did your best, but there's not a lot of responses really. I mean, an awful lot of people walk. I think there were more people walking than driving in the survey that you did. I know it wasn't the vast difference, but a lot of people walk. And these are the people that will be really disadvantaged. And you mentioned the transport improvements that might come with the developments, Sandalford and the other proposed new development up there. Well, I don't know when they will happen, whether they'll happen before or after your surgery, but the people up in that direction, they also have Falkland surgery that they can go to. So we're really focusing here on the people in the town centre who will have to traipse up to you. So they're the ones that are disadvantaged. So the question of making the most of the transport whenever it happens on the new estates, I don't really think that's going to help the people in the town centre a great deal. And I mean, I think I'd be looking at, you know, providing a minibus, you know, that will trundle around, going out to the racecourse and picking up those people that used to walk. So I think that's something you might have to discuss with Greenham Trust or find somebody else to sponsor. That's what I'd be asking for.
Perhaps the people walk to the surgery because they can't drive and leave their cars here as well. So it may well be that people walk not because they can't drive, but they may walk because they can, but they can also drive. So I think it's people walk not necessarily because they can't drive, you know, so it's quite possible there's people that currently just walk because they actually can't get their car in the car park or can't locally.
Well,
I understand what you're saying, but I would hope that with new development up there, new housing, and there's going to be a hospice hopefully there as well, and ask that they actually will improve transport links to that side of town. I'm not sure what the development for that will be, but I would hope that that's something that will happen. I think it's also important to remember that there is no land for us to develop in the town centre for practice. We've looked for the last 7 years. There is no land in town centre for us. So we either move that little bit out of the town centre, or we don't have a practice that we can take on new patients with.
I think your report shows all the trouble you've gone to find a town centre site. So we totally appreciate that. So it's the transport links you've got to provide. And I think your comment that people might now drive who walked. I think you're not, what about the climate impact of that? We should be trying to get people to walk and bus. We don't want more cars, trips going up to your surgery unnecessarily. But I'll leave that there for now. Councillor Codling has a question and then back to Owen.
Yeah, I have a couple of questions actually. What is the area that your practice covers in Newbury?
Liz, I'm going to pass that over to you.
Okay, yes. So our practice boundary runs north. So as far north as the canal, as far south as Burfield. And if we go in a east direction, we go to the racecourse, the edge of the racecourse, but there's a new bridge. So anything the other side of the new bridge at the racecourse, that catchment belongs to Strawberry Hill. And if we go west, we go out as far as Enbourne, down to Washwater, and that's sort of where the practice boundary is.
Okay, so that seems quite a big geographic area. I know you're not keen on having two sites, but to me, it lends itself to having a town site and a separate one that covers the other areas. It's almost as if you actually need two separate practices, you know, and I'm not trying to feed anything in there. It just seems quite difficult. And the other question I had was, you've currently got 15,500 patients. How many are you looking to take from the new site, and would you expand further on those numbers? And I can't see how you can expect to have the development provide the transport for the existing residents. That if you're taking new patients from that area, from the new development, then fine, but not on the existing ones. That seems unfair that you're moving that far away.
Okay, so so Strawberry Hill is a town centre GP practice, and they've got room to expand their patient list. So we are really on the border of the town centre, and a lot of our patients are registered to the south of Newbury. So as I say, Burfield and out to on the A339, Berkshire, that's right. The development up at Sandalford, the new Sandalford development, is within our practice boundary. So we would expect patients from Sandalford to register with us. There's also the Mayfield Point development, where there's going to be a hospice and there's going to be apartments on that site as well. That's also within our practice boundary, as is the development that's going on at Hastings Drive at Greenham. That's all within our practice boundary. We had an exercise done for us with the help of the ICB to predict our populated growth over the next 10 years. And that was up to 28,000 patients that could potentially be registered within our practice boundary. I think, have I addressed the questions that you asked?
Yeah, I think so.
And as far as transport links go, all of the development at Sandalford will have public transport. It has to be part of the planning. Of course, that's not confirmed, but where we appreciate that at the moment there are patients that can walk to the surgery, there will also be patients within new developments that will need to walk to a surgery. There is the volunteer service that provides transport for our patients, and patients can approach our social prescriber in the practice for contact numbers for that service. We also, as a practice, are the only practice that offer a home visiting service, and of which our housebound patients obviously benefit from that as well. So if anyone really couldn't make it to the surgery, we do have that facility if they are housebound.
Okay, all right, thank you, Councillor Codling. Councillor Jeffrey, you had another question?
Thank you. I don't know if it is a question. At this moment, I imagine there's two doctors sitting here who are thinking, when we met Martha and Owen, they seemed very supportive, and now we're getting aggressive questioning. It's not aggressive questioning in any sense. It's the job of scrutiny to scrutinise, and that's the role we're in at the moment. But I want to make, it's pretty well a suggestion to you. You are absolutely entitled to push back on West Berkshire Council and say, we need to move the surgery because the surgery we've got is simply not adequate to the requirements upon it. And in doing that, we're going to have some method of getting people up the hill that currently are down at the bottom of the hill. I think that you can be putting a very strong case to West Berkshire Council, not specifically the Health Scrutiny Committee, but to say that there's a moral responsibility, and it's not impossible, there's also a legal responsibility on West Berkshire Council to be making itself responsible to provide some of that support, perhaps seed funding. And obviously, you know, we have the blessing of having the Green and Common Trust. I wouldn't be afraid of going and asking them if they could seed corn some support. But I think we've definitely got to have some kind of regular public transport going up and down the hill that can be relied upon during surgery hours. I think that is, I think one way or another, that's going to be a crucial element in it. My personal opinion, it's not the definitive view of the Health Scrutiny Committee, but I really do think that that is something that you can push back on West Berkshire Council for.
What do you think of that suggestion, doctors? Hello? You wish to respond to Owen's point?
I think that's a very valid point, and I think that's something we can certainly take forward to West Berkshire Council. So thank you for that.
Okay, I mean, certainly you could approach them, and I think it's probably something that might be done in partnership with other bodies such as Greenham Trust, and maybe West Berkshire facilitates, because obviously we want you to do your best to promote sustainable travel. Hopefully we're not being aggressive, Owen. I think we don't want to be aggressive. We're just trying to explore the different things that we think need to be addressed. And certainly sustainable travel is very important. You know, even if people can drive, we don't want them to have, we don't want more and more cars chugging around our town. But we do want to make sure people have access. So I think Alan has a question.
Well, first of all, I'd like to say that I share the concerns about access, particularly on foot. And of course, not only is it to access on foot perhaps good for the environment, better for the environment, it's also good for people's health. But the question, the other question I was going to ask is, looking at the survey results, there's quite a positive response to the survey. Is 56 people say yes to support the proposal against 8 no's. I was wondering if at the time the survey was done, were people aware of where the proposed site was going to be?
Thank you, Alan.
Yes, they were. So that their results from the public engagement event that we did, and all the plans were on display for them to see at that point. We also, the survey is ongoing. It's on our website with the plans, and patients are submitting their views on that, and it is very positive. And the leading question is that they recognise the need to move. In fact, I haven't had any no's over the last couple of weeks that that's been running.
Thank you.
Oh, that's good to know. Thank you. Thank you for your question, Councillor McRae. Councillor Stevenson?
Yes, good afternoon. I'd like to ask a couple of questions as if the move is taking place. My first question is about IT. Are you going to ensure that all the data that you have to move from your system in the present surgery to the new place is secure? Are you going to have new IT systems? How will you carry out that move of all that IT data?
So we don't store any data on site as such. It's all cloud-based, and it's the NHS England digital programs, or it's very secure network, and that's all operated and supported by our ICB and our local South Central Western IT services. So they would be responsible for making sure that systems were in place in the new site and arrange the transfer over to the new site.
Thank you very much. My second question is, as you've got the opportunity to move, are there any plans to make sure that your new location is a sort of wellness centre where every specialism is available with enough space in your new site?
Yes, well, we have explored the opportunities with, we used to have district nurses, we used to have midwives, we used to have physiotherapy. Well, we've never had physiotherapists, but that's the hope. The plan is that we would like to have those facilities within the new sites. And we had initial conversations at the beginning, but then we were told, let's get the plans up and running to build that service. And then it would involve individual conversations with the various people to get those contracts in place.
Okay, thank you.
Someone else want to comment? No? No. Okay. All right, thank you. Councillor Kanda?
Just a quick question. I'm not sure if I missed it before, but the projected growth in your people within your catchment area, does your new plan cater for all of that potential growth? And maybe that gets back to Councillor Codling's question as well with regards to whether or not actually a split site might work better.
The growth was planned for a 10-year period, using, I believe, data supplied by West Berks Council. Emma, do you have anything to add?
And your new site caters for all of that growth is the question.
Yes, it does. And also the site not only caters for growth over the next 10 years, but it also allows for expansion past into the future as well, because the site would enable us to expand on the current footprint, to actually increase in size depending on increasing numbers over and above that. So it's future-proofing us and allowing us to continue to take on new patients and expand and deliver the care that's needed for an expanding town.
Have we explored whether or not there's any specific transport that's laid on for the college itself from the town centre, as it's kind of next door? I don't know if they have to provide any shuttle buses or anything like that.
There is a bus service that runs to the college. It's not a free bus service. I'm not sure of the exact route that it goes from, but it definitely goes from the town centre to the college.
That's an interesting point, Councillor Kanda. I don't think when we're mentioning buses that we're looking at a free bus service. I think you'd be looking at people paying, and obviously older people have bus passes anyway, possibly that might be used. But yeah, I think that's an interesting point, expanding on what's there already and maybe working with the college and Greenham Trust. So it's a partnership thing, isn't it? So I think that's something. Do you accept that that needs to be explored, that the transport issue, you can't just say, oh, well, there's going to be something provided by the new estates and we have some bus service. Do you accept that that's something that needs to be explored and you'll be sort of proactive in that?
Yes, we do. We accept that. We can definitely look into that further, working with Greenham Trust as well to do that.
Thank you very much for that. I mean, we've had a couple of questions about Councillor Codling about having two sites, and Councillor Stevenson mentioned a wellness centre. We did have a question or a point raised by the chair of one of our patient participation groups, that basically said he thought this was an opportunity, because we've been talking about wellness hubs in the town for some time in different parts of the district, to have a sort of wellness hub in the town centre, which could have some outreach services and include drug and alcohol services, housing, advice, various things, and that this was an opportunity that's possibly being missed. It wouldn't be sort of totally, you know, the surgery there, but it could be explored that there could be some outreach in the town centre as well as your surgery, and that might assist with people, you know, who couldn't make it for all their services. But you seem to think the co-location of all your services together in one building is the most important thing, when I think a lot of people thinking of the survey have actually said that they think this is serving the doctors more than it's serving the patients. How do you respond to that?
The way we work these days is very different to how we perhaps were in the past, which used to be doctors and nurses. I mean, our clinical staff is made up of pharmacists, paramedics, our home visiting team, advanced nurse practitioners, social prescribers. There's not a possibility to be able to provide that level of holistic care on two separate sites. Financially also, it's just not viable. Being able to staff a reception secretarial team two different sites is not viable. So the other thing about it is we do still like to operate personalised lists, which means that we see our patients that are registered with us as GPs. It's much better from the patient's point of view because it provides continuation of care. If you've got two different sites, how would that be managed from the point of view of being able to see your own doctor, or while you're in surgery, be able to go and see a paramedic or a pharmacist and have those appointments too? It's not viable to do that and to be able to staff that effectively for modern primary care over two sites.
Okay, thank you for it. It's good to know. I mean, I saw in the survey that you had considered that, and I can understand that the logistics are probably something that we're not aware of. But from the patient's point of view, you could see how that sort of makes sense to them, really, that from the point of view of access.
Could I just add on the wellness and outreach opportunities? We're doing that anyway, but we do that more widely within our PCN. So we join with Strawberry Hill and Downland Practice, and we've recently been doing health checks in the community for those groups of patients that wouldn't normally come to ours to see their doctor. So we're trying to reach those patients that you know don't visit us, so their health needs are not really being picked up. So we've been running that over the last 6 months, and they've been using various sites. So the Newbury Library has been one of them. They've been at Northcroft, and they've been inviting our patients to that for health checks, and that data has been coming back to the GP, and we've been acting on that accordingly. And we've just recently had another event for patients who have chronic pain and fibromyalgia, and we had a consultant come from the Royal Berks. We didn't have space here to hold the meeting, but we used the Royal British Legion, who were very happy to host us, for us to host it there. So that sort of work is going on already. And as I say, we work within our PCN. So we have 3 practices and try and choose a more central location so that all patients from those sites are able to access those services.
That's interesting information. Is that sort of working with our public health team? Is it? Are we involved in that? Yes. So thank you for that. Another point that was raised by the patient participation groups was at the moment you're part of a primary care network that includes, I think, Strawberry Hill and Downlands. If you go up on Falkland, which is going to be your neighbour, is in a different primary care network, which includes Thatcham and Bird. So
Yes.
is that going to make sense? How is that going to work?
That's always been the case for the last almost 6 years. 6 years ago, we were invited to form a primary care network, and practices were able to choose who they wanted to work with. The stipulation was you shouldn't have a list size over 50,000 patients, and jointly together with Strawberry Hill and Downland and Eastfield House, we have, I think we're at 46,000 now. Falkland, it was their decision to work with catchment practices.
Right. Thank you for that. Do you think, do you think you say your consultation is ongoing,
Yeah.
which is good to hear. Do you think you need help? And we haven't got Bob. We haven't got Bob here yet. Is she there? If we've got Helen on screen, one of the questions we were thinking about was how the ICB could assist you in your consultation. Have you had any assistance from the Integrated Care Board at all? Would you like to have more assistance? Do you think they could support you better?
They've been very supportive throughout the last 7 years. We've had, countless meetings. They've always attended our premises meetings over the last however many years we've been looking to move. They've provided very valuable support and advice with that, and actually provided some money towards the planning commission fee as well. So I think over the years we've had a lot of support from them.
That's good to hear. So you don't feel you need any further support from them as regards your consultation to make sure that you really have got a good picture about the impact on your move on patients. Do you feel you've got a good enough picture of that yet?
The way that the ICB work, we have to follow the process that they lay out for us in where we are. And until we get planning permission, we're not able to move forward to the next stage, which is to create the business case for the move, and transport will be included as part of that as well. I'm not really sure how they can support us with our survey. But if they had any ideas, obviously that we'd be very open to that.
I think Helen wants to respond. Okay, thank you, Helen.
Yeah, I just wanted to echo that the ICB and its predecessor organisation, the CCG, has been working with the practice closely over a number of years now around premises options. As set out in the paper, the next step is for us to receive that business case. And at that point, we would be able to pick up some of these considerations, including whether any further engagement with patients should be supported. But we do need to follow the process as Dr. Featherstone and Liz Pope have outlined, and is also reflected in the paper.
All right, thank you very much for that. Have members got any further issues they'd like to raise? No, I think obviously we want to thank you for joining us today and giving us a very thorough presentation. And I hope our questions have been helpful to help you going forward, with the issues that we think are important. And it's good to hear that your consultation is ongoing. We would like to, and from the chair, I'd like to recommend that that we do hear more about your further impact activities, and that you return to the committee, Health Scrutiny Committee, once your outline business case is submitted, so we can be updated about where you are there and find out whether any of the issues that we've raised have been addressed, and see what's happening. So we really would like to hear more from you, and particularly about how your impact assessment is going as well. Is that okay with you? Okay, so as soon as hopefully we wish you luck in the planning and in progressing forward. It's an urgent thing, so we do hope that things move along quite quickly for you.
Thank you. We really appreciate it, and for listening to us today. Thank you.
Thank you very, very much. Thank you. Thank you very much. So we'll move on to item 7, all age continuing care. And here we have Daphne Barnett. There she is, I think. Interim Associate Director, Complex and All Age Continuing Healthcare, for ICB, and she will give us a short overview of the report on all age continuing care, and then Paul Coe, who's on screen, and Anne-Marie Dodds will have a chance to add their comments. Okay, so over to you, Daphne Barnett.
And good afternoon, everybody. Nice to meet you all, even though it's virtually. There is slides. I'm not sure. Do you mind if I just ask Paul? Did you want me to present the slides, Paul?
Yes, please.
Okay. So, share. Just bear with me 1 second. Okay, can everybody see that or not?
No, not yet. No, we can't, I'm afraid.
You can't. Okay.
I can share for you, Daphne.
Would you mind? That probably be, it's just I'm pressing the share and they're not coming up as a choice.
Now, yeah. Is that because you've done it?
Ah, there we go. That's better. Thank
now.
you. Yeah, that's wonderful. Okay, so this is our overview of all age complex and continuing healthcare. So I obviously don't want to read them out word for word, but the first page gives quite a nice summary of where we are and the difficulties that we have been sort of encountering and working very closely with Paul to try and highlight where the inconsistencies are across all age continuing care. So basically what we have is we have Berkshire West that shows variation when compared to other systems for the referral and eligibility. And further is work to review those variations and try and probe into them to get us to where we need to be to understand what's causing that difference sort of across these systems. There's also an inconsistency across children and young people's continuing care. And the data shows that the referral rates have now increased year on year, but the numbers found eligible has actually remained static, and that's highlighted quite nicely in the graph. And then complex care is further analysis, again looking at that so that we can look at joint funding for individuals who don't meet the eligibility for NHS continuing healthcare or NHS children's and young persons continuing care. And then the governance, what we're also wanting to do is, although we manage all 3 places across Bob ICB, which is, as you know, Buckinghamshire, Oxfordshire and Berkshire West, what we're hoping to do moving forward is to have, although we're going to continue with those neighbourhood services, we want to have more generic access in across all 3 places with sort of governance across all 3 places so that we iron out any bumps in the inconsistency. So that's kind of where we're heading with that. So that's a brief summary on where we are at the moment. And if we go on to slide 2. So slide 2, what we're getting is referral and eligibility variations, which basically in detail will describe the overview I've just given. One thing that we have done when it comes down to the governance, we are developing partnership boards. So we've now had the first meeting. So that's across the ICB and across the local authorities. We've started partnership boards so that we can start that working together to try and drive up the sort of patient experience and also the consistencies across the systems. Okay, go on to slide 3. Slide 3.
Sorry to interrupt, Chair. Certainly at home. There we go. Slides are moving now. Thanks.
Oh, right. Okay. So we're on now slide 4, aren't we? Yes, I'll just go just a little bit on slide 3. NHSE funded sort of over the last year was a local government association looking at recommendations to the ICB. So part of those recommendations we've been sort of building on the my item, but what it's highlighted to us again is that we need to have a single entry point process. We need to have a single QA process to make sure the quality is there, and also a single outcome, so that that process, they go out in a more timely manner. Because another thing that's been highlighted across NHS continuing healthcare and children's is the slowness of the outcomes, and we need to get those more timely, and we need to bring all that into one place so that we can monitor the efficiency of that. So that's something that we're looking at doing to get the equity across all 3 places across Bob ICB. Okay, so slide number 4 really doesn't need too much explaining. I think if you look at the national data for Q1 in 24-25, you can see quite clearly on both of those that you've got Berkshire West as an outlier, along with Portsmouth on the first line, and then on the second line, Frimley and Berkshire West also as outliers. Slide number 5, which once again, looking at sort of fast track for end of life patients. When you look at that, you can see again that Berkshire West is not so much an outlier with referrals. That's quite fine. They're sitting nicely in the middle. But when it comes to number eligible at the end of the period, then we're down again as an outlier. That could mean several things. It could mean that patients have been assessed and then they're not eligible for ongoing continuing care, but it could also mean that they've actually, with them being end of life, have actually died within that projected period of the last 3 months. Okay, I'll put on to slide number 6. What that shows is that across Berkshire West, that packages have been pretty static. So even though you've got some ebb and flow over the last year, what you can see is that the packages are pretty static. So not more awarded, not less awarded, it's about the same. Okay, so slide number 7. So what slide number 7 is showing is the next steps. So what we've got is some working together also across boundaries. So we're looking at working together more closely with Frimley so that we align all our processes and ways of doing things to sort of drive up that consistency and drive out the variation and drive up the quality. That's the whole point of the structures, and the working together is to make improvements. Okay, and slide number 8. So slide number 8 just shows where we are now with our senior structure. So we've been working really hard over November and into December to hopefully recruit to some of the 70+ vacancies that we've got across all age complex and continuing care. And within that restructure, what we are wanting to do is to increase the investment into all age complex and continuing care over the next 3 years, which is to put more hands on the deck to get close to patients so that patients get the assessment. So it's thinning out the management structure and then bolstering up the place teams to the ones who are closest to the patient is the plan. So over the last November and December, current December, we have now got the band 9 is being recruited. We're just waiting for a timeline for coming into post. The assistant director of nursing is still vacant. That's the post that I'm interim covering at the moment. And then the assistant director of operations has been recruited, and we're waiting for a date, obviously, for them to serve notice and come into post. And we've now got all the 8Bs secured in place for Buckinghamshire, Oxfordshire, Berkshire, and for children and young persons continuing care. And we've also got the complex case lead manager who's going to be looking at everything that sits outside of the continuing healthcare eligibility for complex cases joint funds, and they're all recruited. So we now have substantive in all those posts. So that's a real good news story, because now what we can start to do is embed and build the stability into all age complex and continuing care, and also have that working together with the local authority for the good of obviously what we're here for, which is the patients, both adults and children. So that's an overview. I hope I haven't spent too much long on that, and I hope my pace has been okay so that you've had a chance to understand where we're coming from. Okay, thank you.
Thank you very much. Yes, we can hear you very clearly. I'll now invite Paul Coe and Anne-Marie Dodds, who we have here to, I'm not quite sure who wants to go first. Maybe Paul, possibly, is that okay? To add their comments here before we have questions.
Thank you, Chair. Thank you, Daphne, for that presentation. I won't labour the point too long. Yes, I think it's really important to say, to be clear, Berkshire West has been an outlier in terms of these eligibility decisions for a really long time. I have been given lots of reassurances from personnel within the ICB, senior people within the ICB now, to say we're serious about changing that. From my perspective, and obviously Daphne shared some of the changes in personnel, which is an opportunity. So from my perspective, we are now at the start line. And what I need to see, and the people of West Berkshire need to see, is that dial turn in terms of getting the right, fair decisions on eligibility. Thank you.
Thank you very much, Paul. Anne-Marie Dodds.
Thanks, Chair. I'd echo the points that, excuse me, that Paul has made. And what I hope for is a level of consistency and clarity and greater transparency, I think, than we've had around the decisions. And that's not the outcome of the decision necessarily, but it's absolutely the process from start to finish, engagement in that process so that colleagues can be clear how and why decisions are made, and that we can progress this at pace now, hopefully, for children and adults in West Berkshire. Thank you, Chair.
Thank you very much for those comments. Do you want to respond to any of that before I invite members to ask further questions? I think sounds as though you accept all of that, Daphne.
Yes, absolutely. That's fine. We've had lots of discussions, and we've now got the partnership forums where we've openly discussed the differences, and hopefully we can now get that move forward at pace so that it's equitable for sort of everybody, and start making a difference to those patient journeys.
Right, Councillor Codling.
Thank you. Looking at the second to last slide, the next steps, there are a number of actions on there, and the only one that seems to have a timeline is the last one, which says working with NHS England to undertake a further deep dive early next year to consider unwarranted variation. My concern is that that's another deep dive and that's yet another study, but all those other things on that list, what's the timeline on that? When is this actually going to change? You know, to echo what Paul and Anne-Marie were saying, you know, yes, we're at the start of getting things moving, but I don't see when exactly.
Right. So we did have a discussion last week about how we can measure that. So as we're now moving into Q4 of 24-25, obviously we get the quarterly data from NHS England. So what we would expect to see now is by Q4, we probably won't see too much change. By Q1 of 25-26, we should notice a step change in that data. And I would be surprised if we don't.
I'd be unhappy if we didn't. But...
Yeah. But I really would be surprised. I mean, obviously, you know, our biggest issue at the moment is getting recruitment. So we really want to get some people in and get the teams established and get some consistency going there. And I would really be surprised if by the end of Q1 we don't see an improvement. That's my aspiration, and that's where I'm aiming my thoughts to. I'm happy to be challenged if Paul thinks any different, or Anne-Marie, but that's certainly what I'm thinking.
Paul or Anne-Marie, do you have any responses to that? Not really. Okay. Anyway, thank you. That sounds very determined, and I think that's probably what Councillor Codling wanted to hear. So, thank you very much for that promise. Councillor Macrow.
Thank you, Madam Chairman. My point was really very similar to Councillor Codling's. We've had another sitting in the chamber many years ago when we're tackling the CCG on this, and here we are many years later, and nothing seems to have changed. We've had reviews, we've had deep dives. We were told that Buckinghamshire was an exemplar; they were going to take things over and fix things, but here we are still with the same problem. So it's a plea really that let's really get to grips with this and get this problem solved and get the results that the residents and of this district really deserve. Thank you.
Thank you.
Thank you for that, Councillor Macrow. I think you were just basically, yes, stating the obvious. It's getting. Thank you very much. And Councillor
expressing concern.
Yes, thank you, Councillor Stevenson.
Yes, thank you, Madam Chair. On the same slide as Councillor Codling's just asked a question, can I ask about the line implementing the regional disputes policy? That needs to be immediate, doesn't it?
Yes. Yes, so that, yes, with immediate effect. So the NHSE now have a consistent disputes policy, which is national. Obviously, we're accountable to NHSE South East. So that's great, because we now have nationally what is expected by a disputes process. And that now is just in the process of being implemented. So yes, with immediate effect. And this is some of the work stream we can pick up at the programme boards as well, which are now happening. So there should be no reason for that to be finally signed off and implemented.
Thank you.
So we now have a dispute policy, because I think that was one of the concerns that we had. So that's been addressed. So there now is a disputes policy. That's good to hear.
So there's a draft disputes policy, Chair, that now needs fully signing off by all parties.
Thank you very much. I mean, we had, as Councillor Macrow said, we had this peer review in 2023, and there was an acceptance that there were inconsistencies that were not being treated fairly as compared to the other authorities, and yet nothing seemed to change. So you're reassuring us now that things will change because you have the personnel that you need to address that. It doesn't really explain why we've suffered rather than other areas, why our referrals haven't been accepted and others have. Have West Berkshire been making the wrong referrals? Are we not been? I mean, it looks as though we've been making plenty, but they just haven't been converted into in the way we'd hoped they'd be. So there isn't any explanation of why we seem to have been treated differently from other areas. Is there an explanation?
Not as far as I'm aware. Paul probably has been around much longer than myself, would probably know more of that background.
All I would add, Chair, is that I think, as we say, the personnel have changed. So I don't think Daphne can explain decisions made by predecessors or similar. We really must now focus on what's coming next. I could speculate as to what's been the blockers, but I'd really hope that goodwill and commitment on the part of the ICB will take us to where we need to get to.
So you're pleased with what you've heard. Can I just ask a question about something that's joint training is mentioned as something that's advisable in your report. Has that actually started now? Is there going to be joint training? Because obviously this communication, the barrier between health and social care is a big hurdle in lots of ways, and joint training always helps different services to understand each other. Has that already started?
Is that a question to myself, Chair?
I think so, yes.
Yes, yep, that's fine. Yes, so we now have a training lead in the new structure, Nicola Dent. We have already given out some dates for training on the policy, the continuing healthcare framework. The joined up part of it, I think, again, as part of our programme boards, we just need to explore that. I'm a big advocate of joint training. I've done joint training for NHS continuing care at several periods over the last 20 years during my career in all age. Well, it was NHS CHC as it was branded, more so in time gone by. I've run a lot of joint sessions in previous systems I've worked for, where the local authority and the continuing healthcare leads would always set up. We used to do a whole day. So we would do a morning of theory, and then we would do an afternoon of multidisciplinary team scenarios, sort of sat around tables. I'm not sure in this current situation that there's an appetite probably for running anything quite that detailed because of the time resource it takes, but there's certainly still a requirement for doing the online continuing healthcare training, and then that can also be followed up with some joint sort of more place-based sessions. I think that's probably some work stream we need to look at and how we want to design that moving forward.
Okay, thank you for that. Paul's nodding, so I'm assuming that he's happy with your reply there. Can I just ask, the previous applications that have been turned down, was there a process for reviewing them? That might be a lot of work. Is that something that's being considered?
I suppose there's been discussions around it. I suppose the other thing about is what do we prioritise and what do we process, and how do we pull any anticipated backlogs into that? I suppose that's not got a defined answer at the moment. If I'm thinking, there's been discussions, but there's no defined answer. Depends on which categories, which cohorts you're talking about.
Thank you. Anne-Marie and then Paul. Thank you.
Thanks, Chair. I think just to help out there, I think what we will be doing from a children's services perspective is reviewing all of the children that we think ought to be in receipt of funding, and we will be making those applications afresh under this new system, which creates significant additional work, but I think it's the way that we can give assurance that we have reviewed the cases and are asking the right questions.
Thank you for that. Paul?
Yeah, and to add, this is where the disputes process needs to be nailed down as soon as possible, because it will give us an opportunity to properly address gaps where we think, as the local authority, where we believe that the wrong outcome's been reached.
Thank you very much. There is another issue that's raised in the reports about having specific data for West Berkshire, that we've got Berkshire West data, but not West Berkshire. Is this going to be can this be provided? That's for you, Daphne, and will it be provided in future?
So what we're looking at the moment from our management oversight group, we are looking at having different presentations for data, because what we're fully aware of is that all our data that comes out of all age complex and continuing care is probably a little bit old hat now, so it needs a complete refresh. So we've got lean-in service from NHS England at the moment. So what we're asking is that that lean-in help and support works with our business side of a all age complex and continuing care, and they now come up with a suite of consistent reporting for the data across the ICB. Does that answer your question or not?
Does that, Paul and Anne-Marie, is that answer the question?
I think what I would have wanted to hear, Daphne, is we're doing a refresh of the suite of information and the data.
Yeah.
And as part of that, we'll make sure that we've got visibility of local authority cohorts within the place cohort.
Right. Okay. We'll pick that up as well separately then, Paul, to make sure that we're clear. Okay. But there is a piece of work starting on that. Yeah. Okay.
Well, that sounds positive. It sounds as though, you know, everybody's sort of talking to each other, which is what the main, you know, which is you don't make progress unless people are understanding what's happening with each other. Sounds as though we've sort of covered most things. Do Paul and Anne-Marie, do you think there's issues that we needed to explore? Do we feel that there's feedback being collected as you go forward and you start to improve? Do you feel you're actually gathering feedback from clients about their satisfaction? You know, is that going to be collated so we can make sure that we're meeting everybody's needs? Because this is all about getting a fair deal for our residents. So we make sure we're doing the very best for them. So are we happy that that process is being carried out and we know what they're feeling and what their problems are? Yeah.
Chair, yeah, if I can, yes, we'll be clearly what we will be continuing to do is understand the outcomes from individual cases, and we'll have a sense as part of that because we be working the cases with families, whether they believe that the right outcomes have been achieved, and we can understand their experience, not just the outcome but the process and their opportunities to feed into it. I suppose the only bit that I'd like, I think we probably want to bottom out is the ongoing process by which this board will call this report back, and timelines and so on, so that we can hopefully be celebrating the great progress. But of course, we do need to keep an eye on it.
Yes, of course. Thank you. Anne-Marie?
Thanks, Chair. I was similar to how Paul has concluded. I think it would be sensible probably to bring this back in, say, 6 months' time, because we've had discussion about what is going to be different. We don't know yet whether that is going to come to fruition or not. So I think I'd be grateful, Chair, if you could see your way to looking at this again, perhaps in 6 months' time, where hopefully, as Paul says, we'll be celebrating success and we'll be having a conversation about how well the system's working. And if not, then we can explore again in some detail.
Thank you very much. Yes, I think the committee would agree with that, I'm sure. So I'll recommend from the chair that that the situation be brought back to health scrutiny in 6 months' time, so we can see what has changed, hopefully for the better. And also, can we be, as soon as West Berkshire data issue has been sorted, can we be informed of that, to make sure that that is happening, because that seems to be an important issue also. So that doesn't have to wait for 6 months. As soon as that's been sorted, maybe we could be informed. Any further comments? Daphne, is that okay? Yeah.
That's fine from me. Thank you, Chair.
Well, thank you for attending, yourself, Daphne, and Paul and Anne-Marie. And I hope the discussion's been useful. And thank you to members for their questions. Thank you very much. Thank you.
Thank you. Bye.
Bye-bye. Right, item 8. I thought I saw a glimmer of somebody on there and then she went. She's there. Oh, we've got somebody else there. Oh. Okay, thank you. So we're moving on to item 8, access to GP services and integrated neighbourhood teams. So I'd like to invite Sanjay Desai, Associate Director of Primary Care Operations for Bob ICB, to provide a short overview of the report on primary care access and integrated neighbourhood teams. Unfortunately, we haven't got Fiona Warby, Lead Officer of Healthwatch. She's had to send her apologies because we also have a report in the pack from Healthwatch, which members can at least view. We also, who else do we have? So we have 3 people there. I've only got Sanjay.
Hi, Chair. I'm Sanjay Desai. I'm the Associate Director for Primary Care Operations. I've got my colleague Sarah Wise, who's the Primary Care Lead, who's got a Berkshire West facing role. And I've also got Will Gordon, who's just across from me, who will help support us with the integrated neighbourhood teams, if you've got any questions there as well.
Thank you. Thank you very much. It's good to see all of you. So Sanjay, you're going to give us an overview of your report. Is that right?
Yeah, sure. Do you want me to share the slides or have you all got them? What's easier?
You could share the slide. I'm sure that would be useful. I think we have got it, but just in case.
Yeah, sure. Okay, I'll just do that now. Okay. Is that showing, Chair?
Yeah, that's fine. Thank you very much.
Okay, yeah, brilliant. Okay, so thank you very much. Thanks for inviting us. I think between the 3 of us, we're just going to go through just some slides which will stimulate some conversation, and then obviously we can go through any questions that you have afterwards. So we'll talk about the access to primary care. We'll talk a little bit about patient experience, integrated neighbourhood teams, and then the workforce aspects. Just listening to your conversations before this call, and there are certain data which we've got at West Berkshire level and certain data which we've got at Berkshire West, but we can talk about that as we go through the data. Is that going to turn? Yeah. So in terms of GP appointment data, you can see on the slides at the moment that there's a variety of means by which patients can access GPs. Over half being for face-to-face appointments, and that's from September's data, and it's slightly below the national figure and slightly below the BOB figure as well. One of the data or one of the metrics we look at is the time between booking and appointments, and that being within a 2-week period. And about 77% of the patients, the appointments that took place were within that 2-week period. And again, it is slightly lower than the BOB and the Berkshire West and national figures as well. 43% of appointments took place on the day of request though, so just under half of those appointments did take place. So although that data that we've just presented shows that we are below the average for BOB as well as Berkshire West and national, our patient survey that has come out has showed that actually we feature a lot better. So again, in terms of 53% of surveys respondents showed that in terms of getting through to on the telephone was above the national average. And again, in terms of West Berkshire, we had a range. Some for sort of 44 through to about 90%. About 2/3 of survey respondents rated how long they had to wait for their appointment being about right, which is again a positive sign. So they said about 60, which is the national rate of 66%. And West Berkshire, again, the range is as you can see on the slides. Friends and family test as of September was 94% of patients reported a positive experience out of the practices that are within the West Berkshire geography, and the ICB is at 93%. So again, the West Berkshire friends and family test is slightly higher. So again, this is just some of the data or some of the, if you like, narrative that's come out as a result of some of the access work. What we're doing is triangulating some of these data sources together with other data that we've got within the ICB, and we've got a quality framework. And what that's doing, it's helping us to address which areas specific practices need are outliers or need a bit more work. And as a result of that, we are just about to roll out some practice visits across the whole of BOB, but obviously specifically for West Berkshire, we'll be visiting a selection of practices with a rolling programme over 3 years. We will be visiting all of the practices. Now, if something comes up in that 3-year period, we will go earlier than that, but we'll routinely do visits over that 3-year period. And we'll be looking at all the metrics that we hold, be it some of this appointment data, be it some quality metrics, and try and sort of triangulate it all together and then support the practices to see where they need to make next steps. I'm just going to pass you over to my colleague Will, who's going to cover the INT bit.
Thank you, Andre. So INT development is still in its early stages in West Berkshire and Berkshire West in general. It's on the agenda for...
The sound isn't very good.
Sorry,
Sound isn't very good. There's some distraction in the background, I think.
Sorry, we'll try again. Is that better for you? Is that better for you? Can you hear me?
Maybe one of you needs to turn your microphone off. There's two going at the same time, possibly.
You're on mute. So that should be better now, no?
No, there's still a lot of interference. Can your colleague present the INT report? Because we could hear him quite clearly. Is that possible?
So hang on, we're going to swap places. Hang on a second. Yeah.
Sorry, Chair, is that better?
That's better, yes.
Brilliant, thank you. Lovely. So just saying that INT development...
No, there's a lot of interference. It's not better.
Close the laptop. Just close it. There we go. Right, sorry about that. Can you hear me now?
Yes, we can.
Thank you. Right. So INT development is still in early stages, both in West Berkshire and Berkshire West, on the agenda for 25-26. So we're currently in the planning and mapping stages, trying to understand what work has happened historically, both the alignment of community teams to PCNs, some of the MDT working that's been happening, and other examples of integrated working. So that's all being mapped out. We'll be working with system partners, both primary care, secondary community, social care, to understand everyone's priorities and how they would like to best deliver INTs. But it is very early days and it's sort of discussion time, really. And within, sorry.
Yeah, and then it comes to the workforce.
Still sharing.
Yeah.
So we've provided you with some data that sets out the whole-time equivalent, full-time equivalent, and headcount for the main workforce types that are operating within the GP practices. So with this data, unfortunately, is this data is West Berkshire position as of September 24. And what we do need to do is some further work on this to allow you to understand how it compares with the sort of national position or the position across the ICB, and how it compares with practices within Buckinghamshire and Oxfordshire. So it doesn't at this stage provide you with some sort of comparison, but we will work on that for you. But it shows you there's a full range of work staff types that are operating in general practice, and those staff types have been recruited and put in place to meet the needs of the individual practice population. Individual practices as independent contractors will decide themselves what type of staff they need to meet their patients' needs. So you can get variation across practices. So you can have a practice that has far more paramedics working than another, and it will be based on the demographic of their patients and how they need to deliver services. So that data is there, and then we've just provide you with a bit of narrative to put that in context, and we're trying to change the slide for you. But another helpful indicator is to compare what is the average list size per GP for all of our practices. So in practices in Berkshire West, the average patient list size is 1,800. And then according to the BMA, the average figure nationally is 2,200. So that demonstrates to us that for all of our GPs working in our local system, they have less demand from patients than the national position. So we find that a useful indicator to look at. And then we've just set out in the paper some other work that we're doing to support workforce across the ICB area. So I think that's all I was going to say on workforce.
And that's it, Chair. That's the end of presentation.
Thank you very much. Thank you for those presentations. And we now move over to questions from members. Before we start, I'm a bit sort of confused by the pages 52 and 53. Something seems to happen in October. This sort of massive.
So that the drop in the table for appointments.
Yes.
Yeah. So so I can't see what page it's the same. So what our charts show in the data that we've provided is seasonal trends. So you can see that during the winter periods, there's more appointments having to be delivered than there are at other points of the year. So I wonder whether that's what you're seeing.
Yeah, it's just so great. What's so significant about October? You know, is that the same?
It will be the start of the COVID and flu season campaigns. So you might find people going in you'll see peaks at that time of the year because of the administration of flu, etc., and COVID. Is that, or so you're looking at the time between booking and appointments and the drop in the 2 weeks.
It's GP practice appointments and time between bookings and appointments.
Yeah, I can see what you're looking at. So I think we do need to investigate that drop. There is something about maybe a bit of holiday period being seen there.
I think the other thing to note, Chair, is that if you look at the y-axis, it doesn't go down to 0. So it goes from like 85 to 75. So if you look along the y-axis, the left-hand axis, we've exaggerated the numbers there, if that makes sense.
Yeah, it does exaggerate it.
I think I see.
Yeah. It's just so that the graph isn't all at the top. You can then see the differences between them.
Yeah,
otherwise.
so the drop is not as significant as it looks in the chart. Yeah.
All right. One of the issues that stands out is the great variation in practices. 49% to 84%. Satisfaction rates. That's an enormous variation. What's your comment on that? And what are you doing to rectify that? Is this to do with just good practices, bad practices? Or, you know, obviously some practices really need support. And how are you managing that? What are you doing to help them?
So we've introduced a primary care quality framework. That framework allows us to look at all the data that we know on our practices. It allows us to give consideration to soft intelligence that we have. It will start us having a conversation with practices where we think it's necessary to do so, understand what the pressures are, what help they need, what support can we offer them to address it. So that is our intention. We recognise that having a resilient, sustainable primary care sector is extremely important to support the care of our population throughout their health journeys. So we've got to make sure that we work with our providers to make sure they are sustainable. And our intent is to do that by talking to them, understanding the pressures, trying to address those pressures. So that's the main focus of the quality framework that we put in place. If the framework does allow us to manage their contract as well, should that become necessary, but we are wanting to work with them to try and address the variance or at least understand whether that variance is appropriate and should be recognised as being appropriate for the population that they're serving.
Okay, thank you for that. Councillor Kanda?
Hi, so I'm new to the health scrutiny because I'm obviously a substitute, so maybe some of this is already covered, but data is king, right? So at the end of the day, if we take the point in case 44.5 to 89.4 as a range, have we looked into any detail? So for instance, I know my practice recently moved and you used to get the 8 a.m. dial of death, right? You were number 20 in the queue, and actually it came to the point where people would actually go at 8 a.m. to actually talk to the people over the counter, and then they stopped that. But now my practice has actually moved to you fill out a form at 8 o'clock in the morning, and they call you sometime that morning, and they triage you over the phone or over the web, etc. So I can imagine that their satisfaction now has probably gone up. So basically, the nature of my question is, if we look at that range of 44.5 to 89.4, have we looked into any detail? So are the ones that are really bad still doing the 8 a.m. dial of death, whereas the others have actually adopted some new practices? And then as a secondary to that question, before you answer it, is there a standard practice that we are looking to generate, or are we allowing all the practices to do their own thing and trying to find out what's best?
Thank you, Paul.
So I was saying the response to the first part of that question, Chair, is that is something that the quality framework will allow us to do. It will allow us to talk to the practices about their patient satisfaction, and to understand where they are within that. And what I would say about this is the National Patient Survey. It's a point in time, so it's a survey that is published in July, but it's a survey that's conducted in January. And what this data that we've shared with you doesn't do, and maybe we should provide you with further information, is that the satisfaction rates have confidence intervals within it as well. So the range that we are seeing and the variance in our practices, it can be very different. It could be far greater, but I recognise also in saying that it can be worse too. And it doesn't necessarily always reflect what practice's own local surveys are saying, doesn't necessarily reflect what the friends and family test is saying, and it doesn't necessarily reflect what their patient participation groups are saying about that practice. So we need to have these conversations with the practice to understand and to fully recognise where the issues are. And then work with them, as I said, to try and improve where it's necessary that they do improve. The second part of the question about, are we going to make all of our practices adopt a single method of access for their population? They are independent contractors, so they will model their businesses based on them knowing their patients better than anybody else does, and recognising their own staff that they've got, etc. We will continue to promote best practice and share best practice, and we'll make sure that national drivers for online consultations, for example, are implemented, and work with providers about putting them in place in the right way to meet their patients' needs. But what I don't think, my personal view is that you can't say one size fits all, and therefore we will always have GP practices offering different access routes to their services, but we will have a way of ensuring that they learn from each other and understand what is working well, and get the opportunity to pilot different solutions within their practices.
Thank you.
Thank you. Okay. Councillor Stevenson.
Yes, thank you, Chair. A few points. Just can I follow up what you've just said about different routes of access? And I'm very pleased to hear that, because at a recent meeting that Councillor Vickers and I attended of the BOB, we were told that 5% of patients will never be digitally enabled. They're never going to get a smartphone, and we mustn't ignore that 5%. So that was just following on from what you said. But what I'd also like to look at is your last slide. Can I ask a really basic question? What is ARRS funding, please?
So ARRS, it stands for Additional Roles Reimbursement Scheme. So this is a national drive to bring in different staff types into supporting primary care service delivery. So it introduces new roles like paramedics, clinical pharmacists, social prescribers, care navigators, and I'm looking to my colleague next to me to name all the others. But it is recognising that GPs need to work at the top of their licence, and they should only be doing the work that a GP should do, and therefore we need other staff types within primary care to manage the lesser acuity patients, and make sure that that their needs are being met in the right way. So yeah, it's the national way of making sure that the right people are doing the right job at the right time. Yeah.
Thank you. Actually, that brings another point to my mind. Earlier on this afternoon, we were talking about a patient survey, and I remember reading that a patient said that triage helps doctors, not patients. And I'm afraid I think that's probably quite a widespread view. Is there any way that we can encourage a more modern view of triage?
I mean, yeah, it's a good question, actually. I mean, triage is there, obviously, I think you're right, it is to support GPs or GP practices to make sure that the right person is seen, etc. But I think it is also for the patient to be seen by the right professional. So in terms of our primary care strategy, for instance, one of the things we're really driving is around access. But as well as access, we're looking at the patient being seen by the right professional the first time. So to give you an example, if there is a care navigator or, an advanced receptionist, for want of a better term, who then speaks to the patient says, I've got backache, probably the most appropriate person to see that patient would be the physiotherapist that works in the GP practices. So that's one form of triage, if you like, actually, to sort of to divide the patients up to be seen by the right person. So I think there are benefits to patients as well as the GP practice and managed workload.
Thank you. I mean, I can understand it, and I can see why it's brought in, as you've
Yes.
just. I think there are going to be people who are hard to convert.
Yes. Sorry, can I just make I think, because you make a really good comment. So I think some of the piece of work that we're doing is around as I said, our primary care strategy, which I think we have brought here many months ago. But one of the pieces is around communication, and we're working with Health Watch as well to try and get the communication out about different professionals, about the care navigators, to educate the public, to make them understand that when you phone up your GP practice, why are you asked lots of questions? It's to make sure you're seen by the right professional the first time, and to keep reiterating the message. And I think over the last few years, I think the demographics of a GP practice has changed. Going back maybe 10, 15 years, you always saw the GP, then they brought in the practice nurse. You now might see the GP, the practice nurse, the physio, the pharmacist. There's a range of professionals, as Sarah just mentioned, with the ARRS scheme as well. So it is about communication out to the public, and we're working with our communications department to try and do that piece of work.
That's excellent. Thank you. My last question is on the same slide, that you've talked about using the flexible pool. Does that mean, as we seem to be the highest in the southeast, does that mean absence is high, so therefore you're having to bring in staff from a flexible pool? Is that what, have I got the wrong understanding of that?
I think what we were trying to present is that we have a successful flexible pool in operation, that we have a local way of being able for practices that maybe do need staff because others have gone off sick, for example, that there is a way that they can recruit people to ensure that there's continuity of service.
So sorry, so this is a very positive statement then.
I think that's what we were trying to do.
Thank you very much. Thank you, Chair.
Well, thank you for that. Yeah, I think communications is a big issue. So it's good that Councillor Stevenson has brought that up. I mean, we hear of things like anima. I mean, I haven't grasped that yet. Some surgeries do it, and they have offered sort of sessions. I mean, my own surgery, but I haven't been able to go yet. But I mean, you mentioned Health Watch, and I think their report actually, highlights the fact that patients are confused. They still don't understand the different role of the receptionist. So there's an awful lot of work to do. And people, the inequalities and cost of living and all these things that are stressing on people, how are you helping that sector of the population who have great needs to actually cope with these changes? What work are you doing in that area?
Yeah, so I think that is an absolute valid point. I think we've got a health inequalities team. So any of those vulnerable patients or inclusion groups, we will be doing slightly different things around that, working with our health inequalities team. And I think as we said, it is all about communications, and we want to make sure that we communicate in the right way to the right people as well. I think just to stress as well that because, as Sarah pointed out earlier on, every GP practice is an independent contractor. They'll all be doing things very differently. So a practice might suddenly recruit 5 physios, while a practice down the road might not think for their population they're needed. So we've got to try and get the messaging as consistent as possible, but not confusing the public as well, because what we don't want to do is almost raise expectations that every practice has a physio, every practice has 15 pharmacists and whatever. So we've got to manage this carefully. And again, part of the work is working with Health Watch, and we're trying to develop the communications to get it right out there as well. And that will also then include developing some communications for the inclusive groups.
So did you find the Health Watch report? Has that been valuable to you?
Yes, yeah. So we're building on that Health Watch report, and we're working with our Health Watch colleagues as well. And we're just in the process of sort of using some of the comments that they've said to help develop our communications plan.
Thank you very much. Councillor Codling has a question.
Yeah, it's more a comment. We had our Health and Wellbeing Board meeting last week, and we were discussing with Health Watch at the time their report. And one of the things that was talked about was an infographic that they produced.
Yeah.
And we've discussed with them about actually providing that on printed material to put in your surgeries, and also to put in our libraries and other places, so that people can look at it and understand about what triaging is and what a care navigator is, because people still don't understand that.
Yeah.
And as I say, we've offered to work our print room to work with, local surgeries and with Health Watch to produce something.
That would be really, really valuable to us, actually. And I think one of the pleas I was going to make at the end was, could we work together around this? Because I know as local authorities, you've got such a good network that you can get the messaging out to the public. And I think this is where we could really benefit with working together. And in fact, Councillor, the infographic you talked about is the one we think is really good. And in fact, we'd like to almost use that across the whole of Bob, because in fact we had an email today from the Health Watch saying, can we make sure we credit Health Watch for that infographic, because I think it's clear, it's understandable to the public, but any support you can give us around communications with out to your routes would be really, really beneficial.
Thank you very much for that, Councillor Codling. Just another point about GP practices. I mean, we've got an awful lot of stakeholders now who are assisting in primary care. We've got Pharmacy First, we've got voluntary sector, obviously we've got social care, and some of these are being co-located, but not all. I mean, is there any assistance or any improvement in the way GP practices are working with all the different partners? Is that something you're working on?
So in terms of the Pharmacy First scheme, obviously that launched on the 31st of January, so it's nearly going to be 12 months. So in terms of, we will, again, as part of our communications campaign out to the public, we will start working or try to communicate around the Pharmacy First scheme, which will then support our access piece of work. And it goes back to, again, something that we spoke about earlier on. It's making sure that patients are seen by the right professional the first time. So again, just to use the Pharmacy First example, if a patient phones up the care navigator at the surgery and says, I've got a urinary tract infection, the GP practice may then divert them and say, why don't you try Pharmacy First as the first port of call, because that will then free up the GP practice to see other patients with more complex needs.
Thank you very much for that. We've just got an issue here about, I don't know whether Councillor Stevenson wants to comment on this, about feedback from the Learning Disability Partnership Board, where they did a survey about accessing primary care. There was quite a small response, but 40% found difficulties getting appointments or support from GP practice, and concern was noted about timely appointments, face-to-face appointments, difficulties following up, and lack of reasonable adjustments regarding online booking forms. Have you got, I mean, this comes in again, probably, you know, into these vulnerable groups. Have you got any particular ways of ensuring that this group, even though they're not extremely large, there are a significant number, how you're assisting them? Or did you receive this feedback?
We've not had it through at all, actually. Happy to liaise with Vicky and get that through. If that would be really valuable to us, I think, actually. That would be important information that we will take back.
Thank you very much. Councillor Stevenson sits on the Learning Disability Board, so she will make sure that that the feedback you get is up to date and accurate.
That'd be really helpful. Thank you.
Thank you very much. Shall we move on to having a look at integrated neighbourhood teams and seeing how that works? Are you running out of time?
Yeah, no, my colleague just had to leave, I think, just for the work. So in terms of integrated team, we had the slide that we showed you in the pack as well. So in terms of the way we're working is to work with our colleagues as well, and making sure that we work through the integrated neighbourhood teams. My colleague Anna may be on the call.
Yep, I'm here.
Oh, there you go. Go on, Anna. Yeah.
Yes.
Okay, so you gave us a presentation, but I'm a little unclear about how this works. I mean, I thought integrated neighbourhood teams was basically about all the different services working together across the population. Oh, and then we talk about different cohorts being targeted. Are we just looking at one section of the population to start with here, just to sort of work out how the whole thing works? Is that what's going to happen? And what cohort is this going to be? Do we know yet?
Yeah, so the point of starting the mapping exercise is because we know that there are pockets where there are providers who are working more closely together. So the example that we gave there is that oftentimes district nurses will work together with GP practices. And so we know that some of that is already going on. We want to understand what's happening already so that we could build off of that. And sorry, could you say your second question?
What will the cohort be?
Oh, what will the cohort be? Yeah. So the reason that we have been saying to start with the segment, when we've been trying to do this in other places, it helps to understand what patient population you want to try and integrate around first, because that way you can make sure you get the right players to the table. So for example, if you start with frailty, you want to be able to look at kind of what other providers are working with frail patients so that we can bring them in. If you're looking at things like not just our kind of healthcare providers, but folks from the VCSE sector, for instance, we want to make sure that the people that are there are also involved with those patients. And so that's why it helps to start with a patient group. So that's how we've been starting integrated neighborhood teams in other places within Bob. And so it's something that we're looking to explore in West Berkshire.
So do you think GP surgeries, are they ready for this? Do they have the staff? I mean, a lot of this work is going to fall on district nurses and other staff other than GPs, the sort of supportive roles. So
yeah.
Are there enough nurses and other staff to actually support this work and provide the sort of wraparound care, which is sort of what it's supposed to be, isn't it?
Yeah, I mean, that is the idea, is that by coming together, you're stronger with bringing all the providers together rather than just trying to work in isolation. I think we'll find by going through this mapping activity what the workforce looks like, but a lot of integrated neighborhood working is about looking what you already have in the area and thinking about how you can come together to provide better care for patients. So that's the hope. And I think the long-term vision of integrated neighborhood teams is because you're trying to work with patients more proactively and help the kind of more complex patients with the management of their conditions and anything that's affecting their health, that you're also helping them to stay well longer in the community to hopefully reduce some of the demand in the long term. So this is one of those strategies to help try and get kind of more upstream before patients become more severely ill.
So this is about the preventative role. It's
yeah, and proactive care and
proactive care. Helen wants to comment. We're on mute, Helen.
Is that better? Yeah.
Yes.
Yeah, I suppose it was just to say, I think these are all good questions that are being asked, because it is quite a broad concept and it is being interpreted in a number of different ways across the country and in different areas. I think in a way that's one of the strengths of the concept, in that we can make it work in the way that we see best for our patients and that works for the services that we have locally. But it does mean that there's quite a lot of work still to do to define what exactly it is we mean by integrated neighbourhood teams, how it fits in with the overall ICB approach, and also what we want to do locally. I suppose the other thing that I would add is that there is a strong history of partnership working within West Berkshire, and the primary care networks have been pretty well engaged in this sort of work over the years, both when we think of some of the work that they've done around social prescribing and linking in with the voluntary sector in supporting people, but also the history we have of anticipatory care planning, which is aimed at providing the sort of proactive care that Anna describes for vulnerable populations, and sort of lining up services around those groups of people. So both primary care services, but also community services and others. So I think it's important to note that this work is still evolving, but it will be building on what's gone before and on hopefully, very sort of strong foundations for good partnership working within West Berkshire.
Okay, I mean, it's certainly sort of makes a lot of sense. I mean, we had a comment from, I mentioned patient participation groups earlier, and Adrian Barker chairs one of the local ones. I mean, he might be known to some of you. He's also the chair of our mental health action group. And he says, that the vision is great because it brings everybody together. But they've discussed issues around this at their particular meetings, and that he says how much preparation it involves, a lot of consultation to make it work with all parties, and they're looking at a framework in which they can actually do this. And they've already, maybe they could share some of the work that they've done with Bob, to actually sort of, share that what they consider is their best practice and how it might work for them. And I think it was in that context that the idea of a health hub came in, which we mentioned earlier with the Eastfield House presentation, that having what might be wellness or health hubs in different areas, say one in Newbury, one in Hungerford. I mean, this is the suggestion from the PPG and Adrian, would actually sort of facilitate people accessing all these services that we're talking about, such as housing, sort of advice on particular needs, drug and alcohol. So, actually, are you looking at needing more space to deliver these services? If you're not just talking about, liaison between the GP and the district nurse, you're talking about wider working with volunteers and all the services. Are we looking at specific spaces for these? Do we need something like a health hub to actually facilitate this?
I can start with this. I would expect that having more space like that would be really useful to support an integrated neighborhood team. I think that estates is always an issue with healthcare facilities. And so I think the more as partners we could come together to figure out how we could create some of that space or develop some of that space, use any existing estates would be really valuable, because it's going to be something I think would really help support the integrated working. But it's always a challenge with estates.
I don't know whether anybody else has got a comment on that. No? No? Okay. One thing I was going to raise earlier, we don't have a GP at this session, although, you know, we repeatedly asked for one. And I know GPs, everybody's time is precious, but GPs are under an awful lot of pressure. And the only way we would have got somebody here would have been if there was some support, say from Bob, to, I don't know, to sort of support them in some way to enable them to attend. Do you not think that when we're discussing roles like this, the GP is at the forefront of what we're discussing, that it's a bit of a gap not to have a GP here?
Anna, I'll come in. That's okay. So I think, you know, we work closely with the GP practices, the primary care networks, etc. I think right now is a really difficult time for GP practices. November, December, January is their peak time. You know, trying to get a GP out of clinical practice to attend is difficult. We always do try and get them to attend wherever possible, but I mean, they're struggling as well as we're struggling at the moment. But in terms of, just to reassure you, we do work with them, and Anna's team works very closely with the primary care networks within West Berkshire, as do Sarah and I. So we do work with them sort of outside of this meeting. We will always endeavour to try and get a GP to this meeting, but obviously their clinical commitments sometimes supersede the needs.
Okay, so you did your best to liaise, but I appreciate it is a particularly difficult time of the year at the moment. Yeah. It's we can tell because we've got two of our members actually couldn't attend today from our small committee. Yeah. We've got substitutes, so I do appreciate that is an issue. Do members have any further issues, particularly around integrated neighbourhood teams? We've just lost Stephanie for a minute. So unfortunately, we haven't got Health Watch here today, which is a shame because they've submitted their report. I'd like to recommend that we support. Have you looked at the report? I'm sure you have. I'm sure we support the recommendations from Health Watch. We haven't actually seen as a committee the ICB's response to the Health Watch report, which I think was brought to the Health and Wellbeing Board. So we would like to see that. We would like that to be shared with us. Is that something you will do? Helen? Yeah.
So I think I'm right in saying it is included in the report. At the back, there's a response from Sanjay, which was the response that we did discuss at the Health and Wellbeing Board.
Yeah.
Okay, well, we'll look into that and we'll share it with members if we haven't all seen it.
I mean, I think Sanjay, you've already sort of highlighted you were broadly welcoming of the report and the information that it provided and opportunity to work further.
Yeah, so if you look towards the back of the report, there is our section in there as well. And I think they've been really, you know, we've embraced what they've said, and it goes back to the infographics bit as well. Actually, that the previous councillor was talking about. We'll use that to help support our piece of work.
Thank you very much for that. I think I'd like to sort of recommend from the chair that when you have your development plan for integrated neighbourhood teams, that you come back to our committee to share that with us. Do you know how long that might be? How long should we say 6 months or shorter than that? Or how long do you think that might take?
I'll probably look to Helen on this one. I think it's not just something that we could produce as an ICB, but something that's going to mean engaging with all system partners. So I would expect it to take at least 6 months before we'd have something to share, but maybe longer. I don't know, Helen.
Yeah, no, that's fine. I mean, we're doing work on this currently with Anna's colleagues in the primary care team. I think a detailed report probably, or a detailed plan, is probably 6 months. But it's up to you if you would like a more sort of informal update. In the meantime, I hope we will have moved it forward more quickly than that.
That would be good. Maybe something informal for our next meeting, possibly, and that we look forward to maybe getting more sort of information in 6 months' time. So
if we do a brief update next time, perhaps, and then Yeah.
Because you usually attend our meetings anyway, Helen, so you could give us a brief update and then something more formal in hopefully 6 months' time. But we can review that when the time comes up. So that's our recommendation. And also, do we need a reminder there about sharing information? The point that Councillor Codling brought up about sharing information from the Health and Wellbeing Board. Does that need a recommendation? What exactly did you say?
I think it's probably going through Health and Wellbeing Board on the literature. Helen, do you remember? It was, I think we talked about getting some print done, didn't we? I think April Pepperdy is the person to check with.
Yeah. I think April picked up those actions. Yes. Yeah.
That's right. I couldn't remember.
That's good. All right. Thank you very much for that. And hopefully, you know, if you can get in touch with the Mental Health Action Group and see what they're doing as regards their the way they're looking at services and health hubs, etc. I'm sure that would be valuable because that's an important aspect of our care is serving those with mental health needs. Okay. I think we can draw our discussion to a close then, and we've got our recommendation. So thank you very, very much for attending, everybody. Thank you for your time and thank you for the information and thank you, members, for their questions. Thank you very much indeed. Thank you. Bye-bye. Bye-bye.
Thank
you. Where are we? Right. So unfortunately, Fiona Warby has given quite late apologies, the lead officer for Health Watch. You have got in your pack a written report at the back of your pack. So, I mean, looking at the report, they are quite busy. They seem to have lots of initiatives, but unfortunately, she's not here for us to answer questions. If members have any questions, you can feed them to Vicky and she can pass them on to her following the meeting. So don't worry if you don't have anything at the ready, but there are some interesting projects there and they are continue to be quite a small team. So they are doing well with a very small team. Okay. So please read the report and do let Vicky know if there's any issues there. So item 10 is just a verbal report back on the task group that we formed, which is looking at children's mental health and emotional well-being. And we had our first meeting on the 26th of November, where we agreed the work programme and the session plan. There are 6 members of that task group, so it's actually bigger than this committee, which is something we're trying to address. We have actually submitted a request for extra members on this committee because we think we're just too small. More than perfectly formed, but too small. So we'll watch this space as regards that. But our task group has 6 members. We had our first meeting and there will be 3 sessions which will begin in the new year. And they'll be looking at the 3 key areas which are agreed in our terms of reference. So that will be in our minutes if you need to remind yourself of those. A report with the recommendations will follow and it'll be presented at the Health Scrutiny Committee in June. That says June 2024, that's June 2025, isn't it? Okay, so now we have the work programme at the back of your papers, which tells you what's coming forward. So the work programme's on page 63. So next, where are we? March is our next meeting. And then we'll be looking at oral health and dentistry, South Central Ambulance Service, and dementia. So all subjects that have got quite a high profile when we're looking at assessing what to bring before the committee. So as they've all gone through, we have a special prioritisation tool, and if you want reminding about that, I'm sure we can send you out the reminder about how we do that. I'm sure Councillor McCrow knows, but I don't know, Councillor Stevenson, who's new to the committee, do you remember the prioritisation tool? I can't even say it. It's the way we assess what needs to come, you know, the priority in which to maybe we could send that out so you can see how we decide what to bring forward to the committee. And this is a live thing, bringing things forward to discuss. So if members have any issues that have come forward, you know, from their experience in the community or anything they're aware of, please pass that on. That goes for yourself, Paul, as well. Things you think we should be bringing before the committee to be scrutinised. And also there's a form that can be filled in for that, and members of the public are also invited to bring forward anybody out there that's listening. So please, you know, we can look at things that you suggest as well. They would need to go through the prioritisation tool, but we'd love to have suggestions from members of the public. Okay, so thank you very much for that. So I think any further issues, any questions on the reports? No. So I think all the business has been concluded. I'd like to thank everybody for attending. And thank you for your questions, and thank you to all our participations who participated on the screen. I didn't see when we lost Owen. He'd seem to, no? I think he was there most of the time. So anyway, thank you to those who attended on Zoom. And so can you all remain seated, please, until our Zoom host has confirmed that the meeting is no longer being live streamed. Thank you.
Martha, I'm still here.